People abandon cancer treatment every day because the side effects are unbearable. That's life-threatening. And the dirty secret of oncology is that we have no idea if a lower dose would have worked just as well because we never seriously looked.
My oncologist saying, this is the protocol, you either take it or you jump from the window. We thought that the dose was too high. The minimal effective dose of the drug was not clearly established.
Why we don't use the lower dose as the starting point?
Our community of the medical oncologists is not so keen to prevention, is not business-oriented.
He said progesterone is a big mystery.
Metformin alone did reduce cancer proliferation in women waiting for surgery.
Dr. Andrea De Censi, he looked, and what he discovered has changed cancer treatment forever. Hi everyone, this is Joelle from Kicking Cancer's Ass at the 2026 UCSF Rise Up for Breast Cancer and Women's Reproductive Health. I am so excited that a legend in breast cancer, in making treatment quality of life important in treatment as well as efficacy, chose to sit down with me. And this is Andrea De Censi. He's from Italy. He's here. He was a chair of one of the panels. And I'm going to ask him to introduce himself and his background because he'll do it better than me. And I'll tell you a little bit, but Andrea, or Dr. De Censi, can I call you Andrea?
Andrea.
Okay. Andrea, I believe, is the force behind the concept of baby tamoxifen. And now he's researching what's the impact of metformin and intermittent fasting on, I believe, response to treatment or?
Yes.
Great. All right. So let me just start with.
So I am a medical oncologist by training, and I actually, my most important job is treating patients with cancer, but my passion has always been prevention because there's nothing like to see patients with advanced disease to understand the importance of prevention. And unfortunately, however, our community of the medical oncologists is not so keen to prevention because, the treatment of the established disease is very, demanding, but also because prevention is not so sexy, is not business-oriented. And so actually one of my mentors was Professor Veronesi. He's a surgeon who is the inventor of the small surgery for breast cancer in the 70s. And he was very motivated to promote prevention. And I always thought that why, given the success in cardiovascular medicine of prevention, when you treat high cholesterol or you treat hypertension and you have such a benefit in reducing the clinical event, which is myocardial infarction or stroke, why isn't the same in oncology? Because we have 30 years behind them. So I think there is a strong rationale for identifying high-risk patients or women in this case and try to intervene by reducing the process of carcinogenesis, which can proceed by decades the onset of cancer. So this is what actually drove me to do this research in the 80s when I was just graduating, and we did the first big trial of a retinoic acid derivative for breast cancer prevention, and then I started to work on this idea that the dose of tamoxifen given in the treatment setting was too much for the prevention setting, because what happened is that all the tamoxifen prevention trial translated the dose from the treatment setting to the prevention setting. But the population is different, and we thought that the dose was too high. We thought that at that time, the minimal effective dose of the drug was not clearly established. And now the FDA is mandating to the pharmaceutical companies to identify the minimal effective dose before the registration, because the majority of cancer drugs are registered at the dose which is intolerable for the majority of women and cause a lot of clinical and financial toxicity. So that's why we started, as you mentioned, in the late 90s. I'm sorry.
That's why we started.
Yeah, to investigate the minimal effective dose. And we did the first trial on cholesterol, because tamoxifen modulates cholesterol, and IGF-1. So I like simple things that can be translated and everybody can understand. And so we showed that 5 milligram, 1/4 of the standard dose, was equally effective in modulating these biomarkers. And so we went on with a study in the pre-surgical setting, in a window study, and showed that the lowest dose was non-inferior to the standard dose in reducing breast cancer proliferation. And then we did the phase 3 trial, of course, all funded by non-profit organizations, because the drug is out of patent and no one is the sadness here is that once the drug becomes out of patent, the pharma doesn't care anymore. But there is still a lot of research to be done. And so for the benefit of women, for their quality of life, for the reduction of serious adverse events like endometrial cancer, venous thrombosis events, we did this phase 3 trial comparing 5 milligram with placebo and showed the same risk reduction, 50%, with no increased risk of serious adverse events, just the same quality of life, maybe half extra hot flash per day. That was the only result that we had. So I am very happy that our study could help women to, also in the treatment setting, to, if they don't tolerate the full dose, they can de-escalate, and we know that this will not affect the efficacy. So
it actually begs one to question why we don't use the lower dose as the starting point. Because I think your panel today said 30 to 50% of women in the clinical setting, if they've had cancer, were using tamoxifen clinically to treat, can't tolerate and don't stay on it. So why don't they start with the low?
The people always claim about the evidence. And what we did is a trial in women with DCIS or at-risk lesions, not a study in women with invasive breast cancer. So now the study has been done in the United States with the support of the NCI, and the recruitment was very fast, because there is a huge interest in the community to look at this lower dose also in the adjuvant setting. So, but what I do in my clinical practice, many women come to me just because they know of this data, and they say, I cannot tolerate this dose. What can I do? My oncologist saying, either this is the protocol, you either take it or you jump from the window. And I said, well, there is a third option, that is to lower the dose. We know we don't have the proof that it will be efficacious in the adjuvant setting, but the data that we have are very, promising. And so you better go for a lower dose, and they are happy because the majority of them tolerate the dose. and is better than interrupting because so that is but we are looking forward to seeing this new data when they will come in the adjuvant setting. Thinking of low risk breast cancer, not of course the high risk where you may need additional treatments like CDK4/6 inhibitors or even chemotherapy. But
I mean, one of the things I try to share with everyone who listens to Kicking Cancer's Ass is that cancer is a class of diseases. And even within breast cancer, there's, I calculated, at least 140 varieties. And that doesn't include how aggressive each particular tumor is. So it's really an N of one. And I think your point is if tamoxifen is prescribed in the adjuvant, we're getting the research, but if the patient can't tolerate it, it shouldn't be all or nothing, jump out a window. It's, okay, this is the prescribed, it's not tolerable, let's do the baby tamoxifen, get some or maybe all of the benefit, and be able to sleep at night, be able to function and live your life. Now, I want to change gears a little bit. I know that your current area of research is on metformin and intermittent fasting. And my understanding about metformin was, people use it for weight loss. It's insulin regulation. Yeah. And I'm curious why this area of research is fascinating to you.
So I always been a metformin believer, like I am an aspirin believer. All these old drugs, very inexpensive, very few side effects, a lot of data showing a reduction of cancer risk. Metformin is the most used anti-diabetic drug in the world and is, as you mentioned, is insulin sensitizer. So it makes insulin to be more efficient, especially in the pre-diabetic stage. But there are some data also in insulin-resistant women, so women with metabolic syndrome who are in a stage which is very prevalent in the Western countries. They have this abdominal obesity, increase in blood pressure, increase in triglycerides, reduction HDL cholesterol, and this trend to an increase in glucose levels.
That's the way is me. Even though I don't have the obesity, I absolutely was insulin resistant.
It's very prevalent. It's very prevalent in the population. And what we found in a previous study, metformin alone did reduce cancer proliferation in women waiting for surgery, in the window model. And we showed that the reduction was more prevalent in insulin-resistant women, so women with high insulin levels and high glucose level, so the OMA index. But we did a study in the mouse because some data were disappointing with metformin, and the reasoning was that maybe we should tackle two mechanisms of interrupting the growth of tumor cells due to energy balance, excess energy balance. So one mechanism is metformin to inhibit the oxidative phosphorylation of the mitochondria, which is the apparatus of the cell respiration. But if you tackle just this mechanism, the cells activates the other mechanism of glycolysis and keeps continuing to growth and providing energy to the cell. So the idea in the mouse was why don't we lower glucose levels through fasting? And so what we noted is that combining both blockades, so the oxidative phosphorylation by the metformin and lowering glucose with the intermittent fasting, actually created a synergistic effect. So the two mechanisms were more than additive together, and the tumor volume significantly decreased with the combination. So I thought that was, a repurposing of metformin. And thanks to the NCI here in this country, who is doing a very important job, and we have a lot of admiration for this institution, the National Institute of Health. They're doing a great job in doing research, which is very rigorous but also democratic.
I want to thank Paxman for making this episode possible. When I was going through chemo at UCSF in 2023, I used Paxman's scalp cooling system, and it worked. I kept my hair. I was sure I'd lose it. That mattered more than I expected it would. It's the same technology that's helped tens of thousands of cancer patients worldwide over the past 25 years. Because of Paxman's sponsorship, we can share the research and insights from the UCSF 2026 Rise Up Conference with you. So if you're facing chemo and want to explore scalp cooling, visit coldcap.com. Link will be in the show notes. Let's get back to the episode.
So we like, they like the idea. We underwent, of course, a study section with a peer review. The study was approved. And so we did this study in 120 breast cancer women waiting for surgery again. It was a study conducted in Italy, but also in America at the MD Anderson Cancer Center in Houston. And what we have found so far, the data are still premature, but first of all, the women like very much this approach. And considering the delicate moment of their life, because they just received a diagnosis of breast cancer, they waited for the surgery, but they adhere 100% to this idea of eating just from lunch to dinner and then fast for 16 hours from 8 p.m. to 12 p.m. And this lowers glucose, insulin, and other biomarkers of insulin resistance, given in addition with metformin, which is a very well-tolerated drug, may induce some gastrointestinal disturbances in the first couple of weeks of intake. And what we found is this very high adherence, modulation of some biomarkers of insulin resistance, such as glucose, goes down very well. And you can see with the glucometer, which takes interstitial glucose levels every 5 minutes. You see very clearly that the fasting is something that the women do in reality, because there was no peak of glucose in the morning because they don't have breakfast. And whereas in the control arm, there was, of course, the peak of glucose after breakfast. So what we found is a high compliance, modulation of these insulin-resistant biomarkers, modulation of the PET, so the tumor metabolism of the glucose with the FDG PET downregulated. We are waiting for the primary endpoint, which is breast cancer proliferation, hopefully in a few weeks, and we will present the data at ASCO in May in Chicago. But I think this is a scalable, inexpensive, affordable prevention strategy, which is very important now given the prevalence of obesity, of insulin resistance, especially in Western countries. So what I like is the idea of doing simple things that are affordable from Monday, translated in clinic from Monday. And so this is, my philosophy.
All right, I love it. And it seems to me that, insulin resistance, metabolic syndrome is something that if you have it, you do want to get your arms around. And, you studied this with women who'd been diagnosed with breast cancer. I know it's much harder to do the prevention studies because even though, 1 out of every 2 Americans will be diagnosed with cancer in their lifetime, at any given time, it's actually a much, much smaller number. So when you do these big studies, it's hard to get a control and a test. They have to be massive, which makes them very expensive. But how are you thinking about the metformin intermittent fasting for high-risk women who haven't been diagnosed?
Well, these trials are always very challenging because they are very expensive, and so we have to be smart. I'm not sure that the randomization is still the best approach in a case like this. If you do just a single arm observational study, and because of the data of intermittent fasting are growing and are very promising, metformin is very well tolerated. The cost of these procedures are
Nominal.
are irrelevant. I think that an observational study looking at then intermediate endpoints, there are a bunch, could be mammographic density, could be, MRI.
The contrast.
Yes.
BPE.
BP, exactly. It's certainly an approach which goes beyond breast cancer because you can prevent diabetes, you can prevent cardiovascular disease. That would be something that of course, but it takes a few years to look at the incidence rate of the disease and compare it with the, historical controls. That is something to be applicable because I'm sure the uptake would be very, very high, very high. It's not a big issue to skip the breakfast. If you get used, it's not a big deal.
All right. So at the panel you just chaired, I asked you what you found most intriguing, interesting, and you said antiprogestins. And when we were coming up on the lift, you said progesterone is a big mystery. So I'm not a medical person. I'm not a scientist. So explain what's the mystery and why are you intrigued? What's going on with antiprogestins that could mean something different for my daughter's generation, for the people that come next?
So when I graduated, the idea was that progesterone was some way the antagonist of estrogens in breast cancer onset and maintenance of the normal cell growth. But then it turned out with the WHI big trials that progestins, in this case not progesterone but some synthetic derivatives combined with estrogen, were increasing the risk of breast cancer. That was a big shock in the community, not only because the combination did not prevent cardiovascular disease, which was the primary hypothesis, but also because it increased the risk of breast cancer and also breast cancer mortality. So this shock caused a lot of rethinking of the biology. And what we learned is that one thing is the synthetic progestogens, one thing is the natural hormone progesterone. The problem of progesterone is given orally, the half-life is very short and it doesn't, is able to retain the effects durably. So now we have this anti-progesterone drugs which are used for early pregnancy interruption. or for the treatment of fibroids, because they shrink these benign nodules of the uterus. But now the data that are being showed this morning indicate that one of these antiprogestogen, which is ulipristal, but there are others, can also modulate the effect on breast cancer and normal breast cells. So, and they can also reduce the proliferation of breast cancer. So it was a small study, but very elegant, with a lot of, translational biomarkers, and also with MRI. So I think that is a very promising area, although there is a little concern about the liver toxicity of these compounds. So it will be something to look at very carefully, but the mechanism seems to be extremely active. So we have started 30 years ago, 40 years ago, with the idea that progesterone and progestogen could antagonize the effect of estrogen. Now we use antiprogestins to antagonize their effects on breast cancer risk.
Cool thing about science is we're always learning. It's always evolving. And,
yes,
I thought when I heard about this last year that it was really interesting. And, I mentioned to you that I have a daughter, I have a niece, we're a BRCA1 family. We don't know if they have the gene mutation or not, but the drug that I hear about when people talk about antiprogestins is mifepristone, which also has contraceptive benefits and has been studied. It's like metformin. It's been around for so many years. We know what it does.
Yes.
All right. So the last thing I want to ask you, and then we get back to the conference, is a quick answer. What is your advice to anyone who is looking to kick cancer's ass?
So the data that are emerging indicate that we have to be very careful on our weight. So eat less sugar, no sugar drinks, a little meat, especially the processed meat. Have a background, like just to take an example. Exercise a lot, because exercise in colorectal cancer, for instance, there is a spectacular 35% reduction of mortality in patients who had colorectal cancer. It's a randomized study, so the evidence is absolutely much more efficacious than any treatment, drug treatment.
Just exercise.
Just exercise. It's not a big deal. I mean, walking every day, at least 10,000 steps, but if you go to the gym or you can swim, it's a very good one. So this is lifestyle. And for drugs, I think we still need to, do some job, but the evidence that we are accumulating for statins in cardiovascular disease will probably become evident also for breast cancer prevention, colorectal cancer prevention with aspirin, and possibly prostate cancer prevention with some low-dose anti-androgens. But there is a long way to go still for this concept, but I am a believer, so I think the data at the end will come.
The good news is nothing you recommended. Eat well, eat healthy, not processed vegetables, not processed meat, exercise, I assume sleep. None of these are bad for you. So if you do these things, it reduces your risk. And what I found, because I'm a big adherent to those things, it actually, I recovered faster from both my chemotherapy and from my surgery because my body was used to, I lift heavy weight, I do explosive movement. My body was used to, oh, we get knocked down and we bounce back up.
Yes.
And it was just what it was good at. So
the data are even stronger in this context of the reduction of side effects. Yeah, so that's a very important point. And thank you for bringing this. Yeah.
well, I thank you for taking a little bit of time out of this very rich, dense conference. Andrea, it is an honor to share the stage with you, and I really thank you for the work you do and for sharing it with me.
Joel, it was very nice meeting you. For your sympathy is overwhelming. So